Yeah, thank you so much for this opportunity to present today. And thank you, Dr. Trung, for this nice introduction. Today, I'm going to present a case of light chain proximal tubulopathy. A 77-year-old male with a history of hypertension, hyperlipidemia, and obesity. He developed chronic kidney disease secondary to enteric hyperoxaluria following his bariatric surgery, and he also had a history of chronic NSAID use for degenerative joint disease, which was later discontinued. Despite these risk factors, his renal function remained stable for years with negative urine analysis. He had a stable baseline creatinine level at years ranging from 1.5 to 2 milligram per deciliter, and in 2019, his creatinine rose to 2.5 after AF ablation. And in 2020, he had an AKI event precipitated by severe diarrhea and volume depletion requiring hospitalization, with creatinine peaking to 3.6, with only partial recovery at discharge to 3.1. And by this time, he established a new baseline of 2.2 to 3.1. And again, in 2024, he had another AKI event triggered by post-colonoscopy bleeding with creatinine peaking to 3.7 and again with incomplete recovery, and he established another new baseline by this time. So this graph just demonstrates a step-line decline in the renal function over time caused by the recurrent AKI event with incomplete recovery. So we are dealing with a case of kidney injury with rising creatinine level that was initially attributed to several chronic factors like the enteric hyperoxaluria, the chronic use of NSAID, the age-related decline of the renal function, hypertensive nephropathy, and possible renovascular disease, in addition to the recurrent AKI event with incomplete recovery that contributed to the tubulointerstitial injury. However, his chronic kidney disease subsequently progressed with new onset significant proteinuria. Also, his albuminuria was severe. The total protein in urine was significantly higher, suggesting the presence of non-albumin component with a possible tubular or monoclonal process, and the patient was then evaluated for possible paraproteinemia. His complete blood counts were normal apart from the mild normocytic normochromic anemia. Serum protein electrophoresis showed a small spike of 0.2 gram per deciliter, identified as IgA Kappa. Serum Kappa light chain levels were elevated with abnormal serum free light chain ratio of 3.2. Urine studies showed increased urinary protein excretion with monoclonal Kappa light chain band, and all these findings confirmed the production of monoclonal Kappa light chain. His bone marrow evaluation showed normal cellular bone marrow for age with less than 5% plasma cells on CD138 staining. The flow cytometry showed the CD38 positive cells constitute less than 1% of the total event. And the in situ hybridization showed polyclonal Kappa and lambda expression. PET scan was negative. So despite this patient has an evidence of monoclonal Kappa light chain production, there was no overt clonal plasma cell neoplasm on bone marrow or imaging. But given his progressive decline in the renal function and the significant proteinuria, there was high index of suspicion for monoclonal gammopathy of renal significance or MGRS, and renal biopsy was performed. The light microscopy showed a normal glomeruli with tubular injury. We had tubulitis, which was focal on biopsy, and we also saw tubulointerstitial inflammation and edema, the inflammatory infiltrate composed of lymphocytes, plasma cells, and eosinophils, and the vessels showed age-related vascular sclerosis. Immunofluorescence performed on the renal biopsy after pronase epitope retrieval showed that the tubular cast stained strongly for IgA, Kappa, and lambda. But only the Kappa light chains showed these focal granular cytoplasmic staining in the proximal tubular cells. However, these cells were negative for lambda light chain staining that were only seen in the tubular casts. The electron microscopy showed normal glomeruli with no light chain deposits or fibrillary material associated with tubular injury. The proximal tubular cells showed prominent lysosomes with some enlarged and atypical form. It also showed prominent cytoplasmic vacuolization with thickening of the tubulobasement membrane, and no crystalline inclusions were seen. EM is gold immunolabeling for Kappa light chain showed the accumulation of the monoclonal Kappa light chain in the lysosomes in the proximal tubular cell cytoplasm with negative lambda staining, confirming Kappa light chain restricted proximal tubulopathy. So these findings were consistent with a diagnosis of monoclonal gammopathy of renal significance, presenting as non-crystalline light chain proximal tubulopathy associated with IgA kappa light chain restriction. This patient received clone-directed therapy with daratumumab-based regimen to reduce the nephrotoxic light chain production. His supportive therapy included the renin-angiotensin-aldosterone system blockade to control the proteinuria and the blood pressure with close lab monitoring. The goal of the treatment was to control the clone in order to slow the disease progression, even if the renal recovery is partial. Our patient achieved complete hematological response with undetectable M spike and normalization of the serum free light chain ratio. He also achieved partial renal response with about 30% reduction in the proteinuria and disappearance of the urinary monoclonal free light chain band. Persistent tubular proteinuria was noted, reflecting that the tubular injury associated with the light chain proximal tubulopathy can be partially irreversible, even if the clone was controlled by treatment due to the coexisting disease. This patient also had stabilized renal function with treatment with creatinine ranging from 3.1 to 4 milligram per deciliter. However, during the treatment period, he developed an AKI event triggered by subacute diarrhea with volume depletion, requiring hospitalization with creatinine peaking to 4.5, but it returned back to the baseline at the time of discharge. And after completing 6 cycles of the treatment, he was transitioned to daratumumab monotherapy planned for 2 years, and per the treating nephrologist, this treatment preserved the renal function and delayed dialysis for this patient for at least 1 year or maybe even more. So monoclonal gammopathy is defined by the presence of monoclonal immunoglobulin in the serum or urine produced by clonal plasma cells or B lymphocytes. The clinical spectrum ranges from malignant conditions such as multiple myeloma to pre-malignant state like the monoclonal gammopathy of undetermined significance or ANGUS. It also included organ-specific entities like the monoclonal gammopathy of renal significance or MGRS, where a small clone can cause significant kidney injury. Monoclonal immunoglobulin can cause kidney injury with no overt hematological malignancy. That's what we call the MGRS, which is a clonal plasma cell or B cell disorder that produces nephrotoxic monoclonal immunoglobulin. It does not meet the diagnostic criteria for hematological malignancies that require treatment, and it's often referred to clinically as dangerous small clone because even a small clone can cause significant progressive, potentially irreversible kidney damage. And the nephrotoxicity is driven by the unique physicochemical properties of the monoclonal immunoglobulin. Monoclonality in renal disease are identified by circulating monoclonal immunoglobulin in the serum or urine, or monotypic immunoglobulin deposits identified only in the kidney tissue. The term monotypic or isotypic refers to restricted light chain staining in the renal tissue, but when these monotypic tissue deposits match the patient's circulating light chain restriction, it supports a monoclonal process. MGRS most commonly present with glomerular lesions, including the AL amyloidosis, monoclonal immunoglobulin deposition disease, and others like the monoclonal gammopathy-associated glomerulonephritis. However, the tubular involvement is less common, and it includes the light chain cast nephropathy and the light chain proximal tubulopathy, which may be crystalline and non-crystalline. Light chain proximal tubulopathy has several patterns of injury. The crystalline form, which often present with Fanconi syndrome, the acute tubular necrosis or the ATN pattern, which can present with acute or slowly progressive renal dysfunction with minimal inflammation, and the acute tubulointerstitial nephritis or the ATIN pattern, which is the most common one. It can present with acute or slowly progressive renal dysfunction with interstitial inflammation and tubulitis. However, the finding on biopsy could be focal because not all the tubules are in the same stage of the process at a given time. And finally, we have the lysosomal indigestion or constipation pattern, which may or may not present with Fanconi syndrome. So the non-crystallizing light chain proximal tubulopathy is characterized by the accumulation of the monoclonal light chain in the lysosomes in the proximal tubular cell cytoplasm. It can present with the ATN or the ATIN pattern, and the clinical presentation of those patients are non-specific. They mostly present with progressive decline in the renal function and the proteinuria rather than the classic Fanconi syndrome, leading to under-recognition and delayed diagnosis. Also, the light chain restriction may be missed without pronase-treated immunofluorescence, and these cases may be easily misdiagnosed as ATIN non otherwise specified, because in this case, we failed to prove the link between the renal pathology, which is the ATIN, and the monoclonal immunoglobulin, which induced the renal injury, and this prevents those patients from receiving the proper treatment, which is the clone-directed therapy, which can preserve the renal function and prevent irreversible kidney damage. So under normal conditions, the P light chains are filtered through the glomerular capillaries and delivered to the proximal convoluted tubules. These normal polyclonal light chains are catabolized by the endosomes in the apical portion of the proximal tubular cells. However, in the ATIN pattern, when these endosomes encounter this physicochemically abnormal monoclonal light chain, they are unable to catabolize them, and they direct this monoclonal light chain to the lysosomes, where the catabolism is also impaired. So this monoclonal light chain accumulate in the lysosomes. They are transcytosed from the lumen to the contralateral side and deposit along the tubular basement membrane. Dumping of these abnormal monoclonal light chain in the tubular basement membrane can activate the cytokines. It also activates the myeloid dendritic cells and recruits the inflammatory cells, causing the tubulointerstitial inflammation. This is an immunofluorescence for the CD1C marker, which highlights the myeloid dendritic cells with their characteristic long cytoplasmic process that are interconnecting, making this dense network in the interstitium. So the diagnosis of non-crystalline light chain proximal tubulopathy requires some key diagnostic criteria, including the monotypic immunoglobulin light chain staining in the proximal tubular cell cytoplasm, non-crystalline inclusions within the proximal tubular cell cytoplasm by light and electron microscopy, evidence of acute kidney injury, and the history of renal dysfunction. Other supportive features included the EM finding of prominent lysosomes and cytoplasmic vacuolization in the absence of concurrent monoclonal gammopathy associated kidney injury. So the diagnosis of MGRS, including the light chain proximal tubulopathy, is challenging because the underlying clone is often small and can be easily overlooked, leading to underdiagnosis of these cases. It requires kidney biopsy and advanced diagnostic techniques beyond the light microscopy and immunofluorescence, including the electron microscopy and light chain restriction study that are not widely available. And light chain restriction may be missed without pronase-treated immunofluorescence. That's why the Renal Pathology Society and the International Kidney and Monoclonal Gammopathy Research Group recently emphasized that immunofluorescence on the paraffin-embedded tissue should be performed after antigen retrieval using pronase because it improves the detection of the monotypic light chain deposits. Early recognition of this entity is very critical because delayed treatment can lead to irreversible kidney damage, and prompt initiation of the clone-directed therapy, even in the absence of overt hematological malignancy, can slow the disease progression. It can preserve the renal function and prevent irreversible kidney damage. This case highlighted some unique features. While the MGRS is increasingly recognized entity, the light chain proximal tubulopathy is uncommon manifestation of MGRS compared to the glomerular region. The non-crystalline subtype is particularly underdiagnosed, and it also highlighted the rare association of this entity with IgA Kappa light chain restriction. This case also showed the diagnostic challenge in this entity because the clinical presentation of this patient was non-specific. He presented with progressive decline in his kidney function and significant proteinuria rather than the classic Fanconi syndrome, and this presentation was initially misattributed to chronic kidney disease and hypertension, leading to delayed diagnosis. Also, his hematological findings were subtle, with only low level of M spike and modest serum-free light chain ratio abnormality and normal bone marrow examination. However, this small clone caused significant renal damage, which is characteristic of the MGRS. Renal biopsy was essential to diagnose this case. However, the findings on biopsy were focal, adding to the diagnostic challenge. However, the Kappa light chain restriction in the proximal tubular cells on immunofluorescence with pronase and the Kappa label light chain accumulation in the lysosomes on EM with gold immunolabeling confirms the diagnosis of Kappa light chain restricted proximal tubulopathy. Importantly, our patient responded to the clone-directed therapy, which is the daratumumab-based regimen with stabilized renal function, supporting the evidence that controlling the underlying clone can mitigate the ongoing renal injury, and several emerging studies showed that patients achieving complete hematological response or even very good partial hematological response, these cases were associated with improved renal outcome with stabilization or even improvement of the renal functions. So in our lab, in an ex vivo animal model, we were able to maintain the rat kidneys physiologically active up to 72 to 96 hours, and we perfused the renal arteries with the monoclonal light chain purified from patient with biopsy-proven light chain ATIM, and we were able to reproduce similar finding in the renal biopsies of these rats. This is the immunofluorescence for Kappa light chain. It showed the linear Kappa light chain staining along the tubular basement membrane and inside the proximal tubular cells. And also the EM with gold immunolabeling showed the dumping of the light chain in the tubular basement membrane, supporting that the transcytosis is a mechanism involved in the delivery of this monoclonal light chain from the lumen to the contralateral side, where they deposit in the tubular basement membrane. Also, the immunohistochemistry showed increased staining of the KIM1, which is marker that's upregulated in the tubular injury, and BCL2, which is another marker which is overexpressed in the initial recovery phase in the proximal tubular cells. And this finding confirmed that the monoclonal light chains are not just trafficking in the proximal convoluted tubule, they induce injury to the proximal tubular cells. In summary, the MGRS is an under-recognized but clinically significant and treatable cause of chronic kidney disease. Light chain proximal tubulopathy is a rare tubular manifestation of MGRS, and the non-crystalline subtype can present atypically, representing a diagnostic challenge. MGRS is characterized by minimal systemic disease but with significant renal damage, and high index of suspicion is required for diagnosis. Diagnosis relies on kidney biopsy and advanced techniques, including the electron microscopy and immunofluorescence with pronase, which improve the detection of the monotypic light chain deposits. And finally, early recognition and prompt initiation of the clone-directed therapy can preserve the renal function and prevent the irreversible kidney damage. Thank you for your attention.